ribs and their articulations with the vertebra at this point. If we look at a typical vertebra, you have a vertebral body that's located ventrally, projecting posteriorly from the body will be two pedicles. The pedicles have processes that are directed posterior medially. Those are the two lamina. At the junction of the pedicle and the lamina, you'll have a transverse process that sticks out laterally for muscle attachments. From the junction of the two lamina, medially, you're going to have a spinous process. The spinous processes for different vertebra, from top to bottom, differ remarkably. So we'll go over some of the features here in a little bit. This is incorrectly labeled here. It says vertebral canal, but as I mentioned, I think yesterday, that's actually a vertebral foramen. It's not until you stack multiple vertebrae on top of each other that it actually produces a canal. So that's not correctly labeled. On each vertebra, there's a facet. A facet means a place of articulation. So there'll be a superior facet and an inferior facet. The superior facet of one vertebra is going to articulate with the inferior facets of another. And depending on which level of the spinal cord of the vertebrae you're looking at, those facets either form restrictive type junctions, or they form junctions that allow great mobility. For example, in the thoracic region, the facets are stacked on each other and arranged like this. So, and then you have the ribs attached. So if you look at the thoracic vertebra, there's really little movement other than flexion and extension in the thoracic region because it's like that. The facets are like, they don't allow lateral bending. However, in the cervical region and in the lumbar region, the facets are arranged that do allow lateral rotation much more prominently. When you stack a couple of facets, a couple of vertebrae on top of each other, it forms an intervertebral foramen. And it is at that location, that's where you will find the spinal nerve and the dorsal root ganglion. Exiting there, the spinal nerve will bifurcate immediately into what two structures?
Dorsal.
Right, dorsal and ventral primary rami. If you look at, this is one thing I mentioned yesterday, I'll mention it again today, the primary curvature of the spine, or of the vertebral column, and once bipedalism occurs, the development of the secondary curvatures. Know where these curvatures are versus, cervical region is going to be lordosis, thoracic kyphosis. It just alternates back and forth from top to bottom. Between the vertebral bodies, you're going to have the intervertebral disc. The intervertebral disc at about maybe 1/4, again, the height of the vertebral column. It's composed of really two basic parts. There's an outer, very tough ligamentous type ligament attaches bone to bone. Ligamentous type of structure is called the annulus fibrosus. Very tough, circular attachment. You can see it over here in this illustration right there. It's hollow in the middle, and that middle is filled with a gelatinous substance that has a high water content. It's called the nucleus pulposus. Nucleus pulposus. So as the pain progresses and gravity is pushing down on this system, and by the way, the purpose of that, one of the purposes of the disc is to act as a shock absorber for your vertebral column. But as you go throughout the day, the pressure will squeeze out essentially some of that, the water content in the nucleus pulposus. By the end of the day, you're going to be a little bit shorter than you were in the morning if you rehydrated during the night. Not much, but just a tiny bit. Okay? Now, in this illustration up at the top here, what we've done, this view, is we've gone in and removed the lamina. So we're looking at, we removed the lamina and we removed the spinal cord. So we're looking at the back of the vertebral bodies and the disc. There's a ligament that runs from the skull all the way down in the back of the vertebral bodies. It's called the posterior longitudinal ligament. There's a similar ligament in the front of the vertebra, I'll show you later, but in the back, it's called the posterior longitudinal ligament. And you can see that that posterior longitudinal ligament, the fibers interdigitate with the fibers of the I just brain farted. Yeah. The annulus fibrosus. Okay? It's sort of a cruciate form, a cross type form. Okay? The thing about that posterior longitudinal ligament you need to pay a little bit of attention to, you can see how narrow it is. It's relatively narrow. The good thing about that ligament is, of course, it provides strength for the vertebral canal, but it also, if there's a herniation of the disc, the herniation will not be straight posteriorly into the cord. The herniation would occur more lateral to the posterior longitudinal ligament. Unfortunately, when it does that, it usually impinges nerves that are trying to exit the intervertebral foramina, and you have nerve impingement problems like paresthesias. Paresthesias are like pins and needles, or like your limb is going to sleep. It also can produce weakness, muscle weakness, in the myotomes innervated by that nerve. Usually it involves, well, it can involve one segment, and a lot of times it will involve two, because it will hit the root that's trying to pass by it to go down to the next lower level. So when you have these types of symptoms that are associated with a spinal nerve or ventral cranial nerve, it's called a radiculopathy. Most of the time when people present with back pain, the literature is saying that there's really no need to get an X-ray, a plain X-ray. If it's just chronic, if it's just back pain, there's some caveats to that. But and one of them being, if a person complains of back pain and they're having shooting pain down a nerve root, anesthesia or weakness, then that's an indication for not just plain X-ray, but an MRI to rule out something even worse, okay? Or a herniation, for example. Other caveats here that you'd have to worry about whether or not to shoot a plain X-ray is if there's a suspicion that there may be some type of tumorous process or metastatic process going on. Somebody comes in complaining of back pain, has a history of breast cancer, you better bet I'm going to send you right over next door and get you X-rayed. Okay. If we look at the cervical vertebra, the first two are special. There's the atlas and the axis. I'm sure you guys all know this since from kindergarten. They have special characteristics. I'll go over in just a second. The rest of them, though, have unusual features. They have a small vertebral body relative to the lumbar region because they only have to hold up your head. So they don't require that much strength. As I mentioned earlier, they have horizontal facets that do allow a lot of rotation in the cervical spine. Small transverse processes, there are a couple of reasons for this. One is, if you had these big transverse processes in your neck, that would probably restrict movement. And you don't have muscles attaching there anyway. So you don't need that great big of transverse process like you do in the lumbar region. All of the cervical vertebrae, all 7 of them, have a hole in the transverse, in each transverse process. That's called the foramen transversaria. Transversarium is singular, transversaria is plural, foramen is singular, so that's kind of not worded correctly up there. They allow for passage of an artery called the vertebral artery. I'll show you in a subsequent picture. One of the odd things about the cervical spine's processes is that they're bifid. All of the other spinous processes in the vertebra are singular. They're just one blade. This is bifid because of the different types of muscular attachments. And finally, the spine of C7 is long and it protrudes inferiorly. And that's the one you can reach back here. It's the prominent one in the back of your neck. That's why it's called vertebrata prominens. It's really easy, you can't mistake it. So, okay? If we focus on, the foramen transversaria, here's the vertebral artery. The inside the cranial vault, your brainstem cerebellum, is supplied arterially by essentially 4 arteries, 4 main arteries. The 2 internal carotids, which would be right here, this one's cut, that enter the base of the skull. And then you have the 2 vertebral arteries that you'll find in lab here in the next day or 2 that ascend through the foramen transversaria, but they bypass, for some odd reason, they bypass C7. As you see here, they don't go through the foramen transversaria of C7, but they do the upper 6. And once it gets to the top, going through the foramen transversaria of the atlas, there's a groove for the vertebral artery there. The 2 vertebral arteries will join to form this large artery called the basilar artery, which runs on the anterior surface of the brainstem. Basilar artery. We'll see that Friday. Okay. So those are the 4 main arteries of the inside of the cranial vault, I should say. And when people have strokes, you know what a stroke is, right? Stroke is now, since you're grown up, it's called a CVA, cerebrovascular accident. The characteristics of the stroke are different, or the presentation of the stroke is somewhat different if you have a bleed or a blockage associated with a vertebral artery or one of its branches versus an internal carotid artery. So you call those separately the posterior circulation or the anterior circulation of the central nervous system. One thing else I want to show you on this slide, we're going to go into it more detail here, is that the posterior longitudinal ligament. Now remember where we are here. Here's the vertebral canal right there, right? So that ligament is on the back side of the vertebral bodies. You follow me? That's essentially the posterior longitudinal ligament. As you get up here to C1, it widens out and attaches to the skull here more as like a funnel type thing. So it's more like that. Here's the posterior longitudinal ligament, and it attaches to the skull more in a more rounded, not just in one little place. Where it widens out there between C2 and the skull, that's called the tectorial membrane. So in a subsequent slide, we're going to cut through that tectorial membrane to see what's underneath it. So you'll see the incised membrane. And I want you to see where it is intact, so you can refer back to this later. This is how things look on plain films. When you say plain films, this is what you're talking about. Just, you know, having a person stand in front of a digital reader, or if it's an old X-ray, it's the plastic film that you've seen from years ago. From the anterior view, everything looks straight here. There's no curvature, it looks straight. It's only when you turn it 90 degrees and reshoot it do you see actually the cervical lordosis. I'm not exactly sure what this thing is supposed to be right here, but this one right here is the more normal appearance. And when you shoot cervical x-rays, you should be able to see all 7 vertebrae. If you don't see 7 vertebrae, then send them back for a reshoot, because you're liable for all 7 vertebrae. And numbering from top to bottom, there's the atlas right there. There's the axis, 3, 4, 5, 6, 7. It helps when you're shooting cervical x-rays to have, if they're lying down and you're shooting cross table, to have somebody pull down on their arms, and sort of pulls their shoulders down so you can get a better look at C7. When you're trying to look at something like this, one of the things that you pay attention to is the alignment of the vertebra. So if you were to draw a line right here, you see how the anterior lips of the vertebra, they're all in a pretty much nice, smooth arc. You can do the same thing for the posterior side. It's a nice, smooth arc. You can do the same thing for the tips of the spinous process. A nice, smooth arc. You get a step off. That's your first indication that, well, something ain't right here. Okay? The cervical vertebra taken together, the range of motions of the cervical vertebra. Flexion is, and the way I test it in the clinic is I said, as I'm standing in front of them, I'll do like this. Put your chin to your chest. Look up at the ceiling. So that was flexion and extension. Turn around and look at her. Without, yeah. Now turn around the other way and look at her. Touch your ear to your shoulder. Touch your other ear to your shoulder. Okay, so that's the range of motion of the C-spine right there, just illustrated. You know, if a person comes in, if you've got a 4-year-old or a teenager over in the student clinic complaining of a stiff neck and high fever, they don't look good, they don't feel good, and you're trying to rule out meningitis, that's exactly what you do. And you document that the neck was supple, that it had a full range of motion. And supple, that's a word you need to know. Supple is just gooey, you know, or not rigid, I would say. How do you test? So I have an 18-month-old that I'm worried about meningitis in. How do I test the cervical range of motion of an 18-month-old? I can't say put your chin to your chest. How do you do it? No, you don't do that. All you gotta do is, if your mom picked the baby up and have them facing you, what are they gonna do? Turn around. They're gonna look for mom. So if they don't turn around and look for mom, you better get a little worried. So if we look specifically at the axis, or the atlas and axis, starting with the atlas does not have a body. There's no vertebral body of the atlas. Instead, it has 2 arches. There's an anterior and posterior arch. And each of those arches in the midline has a tubercle, and that tubercle is for attachment of certain muscles. We're not going to really pay much attention to, but that's what the tubercle is for. It also has, it really doesn't have much of the way of a transverse process at all, but it does have the foramen transverse area. I mean, it has a transverse process, it's just not not that large. Still has a hole there. It has a groove for the vertebral artery, as I mentioned. Now, there's an important ligament. You see that ligament right there, the transverse ligament of the atlas right there? It has a ligament that runs from one side to the other side of the anterior arch. That ligament holds in place the dens of the axis. The dens of the axis essentially serves the role, or is in, at least is in the location of what would be the body of C1. The dens is a protuberance of the axis. The axis has, again, a body this time. It has two pedicles and two lamina, along with the transverse process and the spinous process. Now, if you look at the articular facets of the atlas, they're sort of kidney bean shaped, and they're somewhat flat. And they articulate with the condyles, the occipital condyles of the skull, which also the kidney bean shaped and rather flat. And that flatness allows the shape of those facets allow for the motion of the head on the atlas to be like if you're saying yes. That's the typical movement there. All right. Versus the atlas on the axis, those facets are more flat, and it allows sort of a no motion that's essentially revolving around the dens. There's one other thing you want to see right here in the dens. There's a little groove there. It's attachment for the alar ligaments, and I'll show you those right now. So, to get where we are, we've removed the lamina, and we're looking at the posterior longitudinal ligament right there, which gives rise to the tectoral membrane that's been cut. Underneath that is a structure called the cruciate ligament. And that cruciate ligament has three different components. It has an inferior and a superior band, and it has a transverse band, which is the transverse ligament of the dens. Okay? Yeah, if you look at the cruciate ligament, you can see the dens up underneath it. So it's got an inferior band, the superior band, and then the transverse ligament right there that goes posterior to the dens. And it helps, obviously, it's helping to keep the dens pressed up against the anterior arch of the atlas. There's another couple of ligaments. The alar ligaments run from the dens over to the skull. That's where you saw that little groove in the previous slide. The groove for the alar ligaments on the dens, there they are right there. These are tough little ligaments that keep C1, C2 in your skull attached to each other.
The alar?
The what?
The alar?
Well, all of these ligaments. If you look on this illustration here, well, let me go back over here. The whole thing is surrounded by what's called an atlanto-occipital ligament that goes from the skull down to the atlas, both anteriorly and posteriorly. The whole thing's sort of surrounded by it. And then you've got this illustration here, which is the mid-side of the section. You should be able to look at this and figure out what these pieces and parts are. If this is the body of C2, there's the dens right there. In front of the dens is the anterior arch. Back here is going to be the posterior arch of C1. These are the spinous processes that you see here. There's the tectoral membrane. There's the posterior longitudinal ligament right there. Anterior longitudinal ligament is going to be in front of it. Okay? And somebody had a good question before class. Like when I put up a thing like this with all this detail on it, and I'm focusing on certain things, it's the certain things that I really want you to pay attention to. However, for practice, I would look at these other structures and try to make sense of them and identify them. You know, even if I don't talk about them, I mean, you're getting ready to start working on people. The more anatomy you know, trust me, the better off you're going to be. So, but as far as test purposes, it's what I'm talking about. Here's the, by the way, so at night when I live here, I go home and I usually have board meetings or something. When I get home about 8 or 9, I sit down and I assemble the questions for what I talked about that day. So if I didn't, that's how I'm trying to get to the end of the week, remembering what the hell I said on Monday, you know, it's not going to happen. But so I do this every day. So what do we have here? Okay, so here's just the direction of the rotational movement of the head on the atlas and axis. So it's fancy figures to illustrate a very simple concept. This is some good stuff and some not so good stuff. Again, this, if you follow these lines down, you're going to see that's a pretty good normal looking C-spine right there from the anterior surface and direction. It looks good. This dark thing in the middle here is your trachea. Now, an X-ray takes a three-dimensional object and squishes it into 2 dimensions, right? But you see all the way through it. So if I showed you this X-ray here, and I said, what is that thing right there, and right there, and right there, and right there, what would you tell me?
Spinous process.
Because the spinous process is going backwards, because you're shooting them en face. E-N, the next word is F-A-C-E, en face. So French for shooting it that way, shooting it en face. Okay.
Wait,
The word,
so the second picture is shooting on Fox,
whoa,
but
who here speaks French? All right, so I'm sure you don't say that word en face, but it means shooting something directly head on. Head on. So if the spinous process is sticking out like that, and I'm shooting it that way, that's en face. So if I'm shooting it this way, you're going to see a circle because you have all of this density of the tube, which is what a spinous process is. If you look to the side right there, what is that little thing right there? That's a pedicle. That's a pedicle. You see the little thing right there?
Oh.
That's the pedicle going back into the plane of the board. Here are the, what is that thing going across there? Well, that's going to be the body right there,
I can't see where he's pointing.
but superimposed on the lamina. Because you're going to see both of them right there together. Down in the lumbar region, they stand out more as distinct structures. We'll show you in that.
Can you point on this one?
No. So that is the spinous process.
Yeah.
There's a little oval right there and right there. Those are the pedicles going back into the screen. And so you see that thing right there, that white thing? That's the combination of the body with the superimposed lamina, because you're taking here together. You're seeing both of them. When we get down to the, like I said, when we get down to the lumbar region, you can discriminate between the two.
Where's the trachea that you're seeing?
So the dark structure in the middle is the trachea, because anytime you put an object of different density in there, you're going to have a different image. So what you're seeing is the outline of the trachea right there. You can actually follow it down all the way into the chest right here. It looks like it's bifurcating right there. Now this right here is what we call a bamboo C-spine. And this is a a straightening of the normal cervical lordosis, usually due to pretty severe muscle spasm. You see it all the time in students who spend all day with their head like this, studying, and then they get like this. And it's the more of this you get, the more inflammation produces more spasm, and it's just a vicious cycle until finally they come in and their neck looks like a piece of bamboo. So a muscle relaxer, non-steroidal, massage, taking a break, all of these things help a little bit to the area. This is not bamboo. This is called a chalk stick fracture, and it's basically it's just like if you take that rigid piece of chalk and try to beat it, it's going to pop. And this is obviously this person is going to be a quadriplegic without a doubt. You see that thing right there in the front? That white line right there? That's an endotracheal tube that's going down the trachea. All endotracheal tubes have a radio-opaque stripe in them, so you can identify it as being in the right tube, meaning the trachea, not the esophagus. Radio-opaque means it's white. X-rays don't go through it, versus radiolucent, which would be like air, is radiolucent. Okay?
What's the thing sticking out?
What is the thing
Well,
stick?
you see, it's like,
Well, that's the hyoid bone right there.
and below it, by like a trachea.
That right there is a port. You see that for, it looks like it's probably an external jugular line or an internal jugular line for infusion of fluids. It's not associated with the endotracheal tube. A couple of fractures that you ought to know about. If you dive into a shallow pool or lake and you put all of your weight, your body's weight coming down on top of your head, a Jefferson type fracture is essentially a burst fracture of the atlas. And you can see several examples of it here. This is a very unstable fracture. It usually produces swelling and damage to the spinal cord. Your respiratory, the drive for your phrenic nerves that runs your diaphragm is at the fourth cervical vertebra. We'll talk about that later on. Not fourth cervical vertebra. It's the fourth spinal cord level. Fourth C4 spinal cord level. So any fracture of the C4 and above, you're going to usually lose the ability to drive your phrenic nerve and you'll die from respiratory rest. Remember Christopher Reeve, the Superman, old Superman? He had a fracture of C2. So the only reason he was able to live is because somebody was giving him mouth-to-mouth right there when he fell off that horse. Otherwise, he would have died on the spot. And if you ever notice him in his wheelchair later on, he had a tracheostomy and a pump that would fill his lungs. So I remember some awards show he was on, his lungs would fill from the machine, and he would talk like this, and he would be able to continue his conversation. So it was only the machine, it was only when his lungs inflated and the mechanical pressure of his chest deflating, or he couldn't contract his chest or his diaphragm. Just the weight of it, it would force air out, and he would be able to talk for a few words before he had to wait for his lungs to fill up again. Okay? Jefferson fractures, you see these quite frequently in the ER. They're usually dead on arrival, and there's usually alcohol or drugs involved, or both. It's like the famous last words of an Oklahoma redneck, "Hey, watch this." So, as opposed to a hangman's fracture, that's a C2. And this is a little bit not illustrated properly. It's best if you do the noose, if it's around laterally. So when you drop, your head will snap laterally instead of forcefully extended. But nonetheless, what you wind up with is a fracture through the process, the pedicles, essentially, of the C2, and that's going to put all the pressure on the cord, and you're going to die. So when a person is hanged, so instantly the diaphragm's not going to work, and you're not going to have blood flow to the brain, but the brain can survive without blood for about 6 seconds. So for those 6 seconds, the person is going to be aware of what's going on before they lose consciousness. Although no one could ever prove that because you can't talk. So anyway, it's kind of interesting. There's a whole science behind being hanged, and that's one thing I don't understand. Why is it not they were hung?
Yeah.
They were hanged. I don't understand that.
Curtains are hung.
But,
People
you know,
are
there's a
hanged.
whole, if you read the science, it's kind of interesting because, you know, depending on your mass, that determines how far you drop. Because if you drop too far, your head will pop off. If you don't drop far enough, you won't burst C2. And so you'll struggle. So you'll suffocate from, so anyway. Any questions about that? Now, this one is a little different. This is a rupture of either the transverse ligament of the atlas or the dens itself. In the illustration on the left here, what's happened is the ligament is ruptured and the dens has slid, or actually the atlas has slid forward, crushing the spinal cord. This is obviously not compatible with life. And the second one, you have a fracture through the dens off of C2. It produces the same thing. It can produce the same thing. There's Steele's rules of 9, thirds, Parkland's little brain. Steele's rule of thirds is that if you look at this distance here with the CT, the dens should equal 1/3 the width. The spinal cord should equal 1/3 the width. And in front of, in back of the spinal cord, there should be 1/6 or 1/3 when you add them together. And so if you don't have that, then you need to be thinking about a dens or ligament problem. If you take one of the, when you're x-raying somebody with plain films that you're concerned about cervical injury, you're going to get an anterior-posterior view, you're going to get a lateral view, and then you're going to get another view when the patient opens their mouth and you shoot the direction of the beam is going through the mouth. And that produces this illustration. Here, you can see the arch of the ring of the atlas is right here. There's the arches right there. There's the dens, and there's the axis there. This would be the mandible with the mandibular teeth there. Okay? I had a patient one time come into the emergency room. He brought somebody else in. They'd both been in an accident the day before. So he brought somebody else in, and I can't remember what the other guy had, but it was something not consequential. But he was complaining about, the driver was complaining about, his neck hurt from the injury. And I said, whoa, wait a minute. Let's take a look at this. So I didn't even put him in a seat collar at this time. But I sent him on down for x-rays, and he had a complete fracture through the dens right there. And that's what you're looking for, is that dark line going across there. And sure enough, his dens was completely fractured off of there. And he was in there saying, my neck hurts, so then he had a seat collar on. I had a guy come in to the ER one time. Tell me how dumbass people are. His wife, he was 40-something years old, I remember this clearly. His wife told him, if you go to the rodeo, you do not ride, you're the spectator. So he went and rode anyway. And so the ambulance brings one guy in who had been bumped off a bull, had been knocked unconscious. So I have him down there in the scanner. And the other guy had dislocated shoulder. And so he was out there when he dislocated it at the ring, whatever you call it, arena. He tried to get it back into place. You know how Mel Gibson did on that movie? Doing this and trying to get it to go back in place because he knew if his wife found out that he had got on a horse and was bucked off and dislocated his shoulder, she'd kill him. So I said, hang on a minute, let me finish this guy in the scanner because we only had one tech. After she got the scan, then I'll get you down to get your shoulder x-rayed. So I go down there and deal with the scanner guy. He was fine. Tried to admit him, but he wouldn't stay because he's a cowboy and you're not going to stay overnight in hospitals. So he left against medical advice. He left AMA. So I go back down there to the ER, which was just down the hallway, and there's this guy. The gurney was right here. He was standing there beside the gurney, trying to get his shoulder to go back into place. And it was clearly out of place. It was clearly dislocated, just looking at him. So I sent him down there to get his plain films. And not only did he have a shoulder dislocation, he had a complete transection of his humerus was completely fractured across it, completely. And this, I couldn't believe it. I mean, I would be on the ground screaming like a wild banshee if I had that fracture. And he was just banging it
Assuming the cord's not severed, it's just has so much pressure put on it, do you typically die from just not being able to breathe?
Yes.
Because the information can't transfer?
Yes. I mean, if you
What actually kills you?
yeah, spinal cord injuries, very rarely do you have actual transection of the spinal cord. Back in that chalk stick, yeah, it's going to be transected. But most of the time it's compression, spinal cord compression, or inflammation. That's why anytime you suspect a spinal cord injury, the first thing you do is you give them a whopping dose of steroids to try to reduce the inflammation that's headed for the area. So after a spinal cord injury, as you recover, over a period of a year, you usually regain some of your function if it's not complete, if it wasn't a complete injury. And you tell patients that, at the end of the year, whatever motor or sensory function you have at the end of the year, that's probably about all you're ever going to have. So it's very variable in how well you come back. There was a patient just a few weeks ago, the case finally settled. A lady shows up in the rural emergency room here in Oklahoma, and she had, she claimed she couldn't walk, and she was having radiculopathy on both sides, which is an alarm because you shouldn't, it's very rare to have radiculopathy on both sides. Anyway, the PA examined her, and at the time she walked just fine. She didn't have any, her neuro exam was completely normal. He discharged her with, pain control, anti-inflammatory, something like that. Next morning, she winds up quadriplegic. And it turns out that she had, if I can go back, if you'll bear with me for just a second, she had a very unusual injury or process going on. She wound up herniating both sides right here. And the herniation of the disc went around the posterior longitudinal ligament and put pressure on the cord. So once they got her in surgery, got the pressure off, got the nucleus pulposus out, and over a period of a year, she was completely normal. Completely normal. And, but for a time there, she was a complete quadriplegic. So what did I say about malpractice the other day? What did I say about malpractice? It has to involve injury. So this happened in 2014 when the case was filed, when she was a quadriplegic. Today, she's perfectly normal. There is no injury. So they did not take the case to court. You have a question?
Yeah, would that show up on an MRI?
Oh, it definitely did.
Okay,
Now,
so,
he did not MRI her that night.
okay.
So, here's the thing, here's the defense argument is, why would I MRI a person with no symptoms? When she came to me, she had no symptoms. You know, the fact that she appreciated Lortab, I'll say it that way, she appreciated Lortab and comes in complaining of, well, I have neck pain and back pain over there, but I have nothing right now. No insurance company is gonna let you MRI them, so, and pay for it.
What do you mean by over there?
She had a long history of her primary care provider feeding her Lortabs.
Gotcha.
Versus by the time she got to the ER, and this was actually, she was referred to the ER, wasn't in the same town. She had no symptoms.
So when it's a bulge disc, it's actually the nucleus pulposus protruding out.
It's a nucleus pulposus, essentially, that's pushing the ligament, the annular ligament
So
out.
you're saying with her, the ligament itself ruptured.
No, I'm saying with her, it looked, so ordinarily, if this was the annular ligament, you'll have a, like that. With her, it was more like that, and that was putting pressure on the cord. Okay? All right. This is a similar picture to the one that I showed you earlier. Now, the only thing I want you to do with this picture is sit here and look at this area right here. There's the base of the skull. So there's the foramen magnum. It's going to be right there. There's the anterior arch of C1. There's the posterior arch of C1. That's C2. There's the body of C2. There's the dens. Okay? What ligament would that be? That's the transverse ligament of the atlas. So I want you to take a look at this and just kind of confirm in your own mind that you can identify these structures. Why don't you take a break and then we'll come back and knock out the rest of this.
Can you point that on this screen? Please?
So there's the foramen magnum right there. You're not going to see it in the back because it's not a picture. There's the front of the foramen magnum. There's the anterior arch of C1, posterior. There's the body of the C2. There's the dens. So in front of the dens is going to be the transverse ligament of the atlas. Right? Okay.
Gotcha.
That right there would be the posterior longitudinal ligament. Right there, that's the anterior longitudinal ligament.
Where's the posterior?
The what?
Right there, right?
The posterior longitudinal ligament is going to be right here.
Okay.
Anterior longitudinal ligament is right there. If you guys want me to take a break, we'll keep going.
No.
I got you ready.
Oh, gosh.
So good.
Yeah.
Maybe like one or two things.
Isn't that between that